this test subtracts these two, so this purple line should be what we think is just coming from the detrusor. So it's a subtracted cystometry. And what do we see here? Well, this line should be just nice and flat, but it's not, is it? It's got these peaks. These peaks are increases in pressure. So in the detrusor, we're getting increases in pressure during filling in what should be quite quiet. So my very stylized diagram at the beginning is not happening here. We're getting some contractions. Now, if you also have a look, when we get these peaks, we get activity here. We get activity here, which is somehow compensating for those feelings of urgency. What we don't have here is an EMG line, but some of these tests also have EMG electrodes sitting on the surface of the perineum, and then you can see really well what the voluntary muscles are doing at the time of pressure rises, etc. in the bladder. And this is how we understand what the nature of the dysfunction is during filling and during emptying. So these spikes are occurring intermittently, so we would call this Detrusor overactivity is the name you give to the overactive bladder when you see it on a urodynamic trace. It's a urodynamic term. If you're seeing a child in the clinic, they can only have overactive bladder. With me? And now this is another child who's having a few increases in pressure, but not as severe, you would say, as the first child. But what I want you to see here is this bottom line is the voiding phase. So nothing's happening. They have an urge here, they have an urge here, they have an urge here, where they, as you see, a rise in pressure, they have an urge, a little bit of activity here. And then, this is a nice normal void because the pressure goes up, some urine, they drop their compensatory mechanisms so that some urine can enter the urethra, and then they can start to void. And it's the timing of this, and this occurring together that tells you that this is a coordinated void. You don't need to know this was interesting to tell you how it works together. So this chart, I'm not worried about their voiding. This is what we would call a normal, almost bell-shaped curve. Very rapid rise, but that's okay. And a nice big void, and then it empties. But what we're seeing here is some detrusor overactivity, but it doesn't impair the emptying phase. And we're not always lucky enough to get access to this information because I don't think most children with detrusor activity here in Australia would be having these tests. And here we've got something again. You can see that the pressure is up and down, baseline, and then up and up and up and up and up. And you can see, we see this in the bladder and we see it in the subtracted version. And this child has activity going on in this line here, telling us that they're feeling the urge and they're trying to do something about it until the pressure drops, some urine goes into the urethra. 1 second later, you should start the void, and it's a nice normal void shape here. These are just a few more showing you increases in pressure. And this one here showing you with this increase in pressure, this child is trying their hardest to get all their compensatory mechanisms going, whether they're using pelvic floor muscles or they're pulling in their stomach or what they're doing, but they're doing it again here. And this is not an ideal void, probably because they can't actually relax these compensatory mechanisms well enough to start the void. So why does this occur? I don't think that there's a big case for you just get it. I think there's reasons. It's probably not maturation lag unless you've got some other disorder up in the cortex. And as I said before, we are seeing more and more children with behavioural disorders are more likely to have this sort of symptom. There was a number of years ago some genes that were identified, but that genetic research, to my knowledge, hasn't developed any further. I think it's quite often related to voiding disorders. You could learn this overactive bladder in the sense you learn to have uncoordinated voiding during your toilet training phase, or if you had infections when you were little and you learned to contract the pelvic structures to make it hurt less, if you were constipated and you learned to hold in everything so you didn't have to pass a stool that was going to hurt. We know that those two factors are certainly likely to be involved in the etiology of overactive bladder in children. There's probably a neurogenic contribution, but we don't know about it yet. We can postulate because we understand the relay centers that are in the cortex now, but we're still trying to put those together with behavioral presentations. We know that it's associated with dysfunctional voiding, and I can talk about that later. And I've explained to you that I believe it's secondary to these high pressures in filling that you contract the structures supporting the urethra. And this then gives you a sort of a functional contraction to obstruct the voiding if you can't then relax those structures. We know that from adults that if there's really high flow rates, then you get more pelvic floor activity to dampen those down. And if there's very high pressure, you get pelvic floor activity to try and dampen the high detrusor pressure in order to protect the upper tracts. So there's this possible cycle going on during filling and emptying. Okay, let's look at these disorders, other disorders of storage. I talked to you about the endothelium and what happens with bacteriuria and inflammation, post-infection and chronic repeated infection. And this may well change the messages ascending to the cortex. Now in adult women, we are seeing stress incontinence very often. That is when you don't have the appropriate closure pressure coming from the pelvic floor and the voluntary structures. We don't see this routinely in children unless there is some reason that the nerve supply to the voluntary structures of the pelvic floor has been damaged or there's a real weakness there. And this may be the case where if you think about the pelvic structures as being the trampoline, and if there's repeated increased intra-abdominal pressure and the muscle descends a lot, such as if you cough, our CF girls, if you have hay fever, if you strain a lot to constipation, if you're a road runner or one of those high impact sports, maybe then you'll get some stress incontinence. But in the main, if you get a referral for a child with stress incontinence, probably not. So you need to do a really good assessment and look for all the other symptoms. Giggle incontinence is something you'll come across from time to time. And this is when a child, boy, girl, or an adult laughs and they wet themselves. There's a sort of a joke, I don't do that, I'll wet myself. But there is a group of people who really do wet themselves when they laugh. And we just can't identify what is the underlying mechanism. It seems to be that anatomically they are fine. If we look at the way the bladder stores and empties, it seems to be quite reasonable. We know that we'll see it in families, and we think maybe there's some spontaneous relaxation of the urethra. Maybe it's something to do with the relay stations in the cortex. We don't know. It's sometimes being treated, but there's not an evidence base for this, but it's sometimes being treated with ADD medication and had some response. It's a difficult condition, and there are some things that we can do. And then we have disorders of emptying. How am I for time? Good. Now, do you empty too frequently? Do you empty with an odd stream? Do you have pain when you empty? And do you have a concurrent disorder of the bowel? Now there's a thing that you'll see called the extraordinary urinary frequency. You won't see it that often, but it's very obvious. There's a sudden onset of excessive frequency. And these kids, poor things, they are going to the toilet every 15 minutes. They are just over it. It starts all of a sudden and it stops about 18 months later. And there's very little effective treatment that we can do in the meantime. They don't have the other disorders that we might expect to see. The bladder stores fine at night time when they're asleep, and they're never wet. They just have this incredible discomfort and sense of urgency. And so there's something going on in their sensory feedback mechanisms, and some people say they have high levels of calcium. Other people say it's like a sympathetic disorder. The urine might not be very easy to store. We know that acidic urine is very difficult to store, and sometimes you can neutralize this urine and they're a little bit better off. But basically that's a condition that's tricky, but you will see it. And we've talked about the increased frequency. I would just say to you that you will see this in girls after the menarche too, and it can be to do with where they are in their estrogen cycle, particularly when there's prostaglandin swings. Very often when you have high levels of prostaglandin, you have this frequency. It might also be, as I said, something to do with creating inhospitable urine. I had one girl who just ate a lot of mandarins in mandarin season, and this disagreed with her ability to store. And you've all heard about caffeine. Now there is some evidence that is good evidence that caffeine does make it more difficult to store urine. A lot of what we do with this bladder training is not evidence-based, and you have to be quite careful to not present it as we know this for sure. But there is evidence that says that we know that caffeine in some people can irritate the lining of the bladder and make it more likely that the detrusor will contract during filling. Then there's the other end of the spectrum that I told you about, the infrequent voiding, and it has had names in the past, the most unglamorous of which was the lazy bladder. We don't use that term anymore. And it's basically when the child doesn't void enough times during the 24 hours. They void large volumes, they can't empty easily. The mechanics of being over-distended make it difficult for you to empty easily. So what will we see as an objective sign? We'll see that the flow rate, when they pass their urine over a flow meter, it isn't a nice bell-shaped curve. They either can't generate much pressure, so it's a low curve and long, or it stops and starts, and they usually don't empty to completion. So you can imagine that these children will also be keeping some urine after their void. They're much more susceptible to urinary tract infections. Some of these children might be wet, but not all of them. Often they'll have enuresis at night time, and often they have associated bowel dysfunction and, as I said, infections. Then there are mechanical reasons why the stream isn't as we would like it, and it might be right at the end of the urethra before the urine passes out. It might be the meatus in boys is fused, so it creates like an obstruction there. And you could see that the stream goes in all directions, a split stream, it takes longer and the flow rate isn't good. If it's a boy and there's something odd about the flow, one of the first things you ask is, did you have any operations when you were little? Because a condition called hyperspadias is where the urethra didn't come out in the right place and they had an operation, fixed all that up. Very often you can develop a stricture inside the urethra later, at 6 or 7 or whatever, and they've forgotten by then. You know, they're all fine. Did you ever have an operation? Oh, yeah. So if they had a stricture, then that needs to be maybe made, that scar tissue might need to be removed. Now, girls, we have a mechanical entity called vaginal reflux, and if you can think about the labia in pre-pubertal girls, very often it sits together like this. It's quite sticky and adheres to the labia adhere to each other. And if you then get a girl who doesn't sit on the toilet in a nice big wide open way, because it's a challenge for a young girl to sit on a toilet and have to have their belly hanging out and their thighs big in there. So a lot of girls perch on the edge because they've been taught that that's a clean way to do it. And they have hip adduction, and those girls can very often funnel some of the urine coming out of the urethra down into the vagina. And it sits in the vagina because of the angle that they're on the toilet, and then they come out, wash their hands, bend over, do up their shoelaces, whatever, they get wet. As soon as they change posture, change the angle of the vagina, the urine comes out. This is a really easy thing to diagnose because it will be the classic history over and over again. And if you can teach this child to have an anterior tilt on the pelvis with their thighs wide apart and their labia open, and they can see the flow of urine, you shouldn't have the wetting afterwards. So it's almost self-diagnostic. And then we have another mechanical disorder that I think you might hear about later today, just to say that in some boys in the utero period that they grow membranes almost across the whole of the lumen of the urethra, maybe not entirely across, and these set up an obstruction inside the lumen, and the bladder doesn't develop normally because when you're emptying your urine, even in utero, it's putting too much stress on the bladder, creating a resistance, and these children have to have that tissue removed. And they also may have strictures later on from the remnant of the tissue. And this is associated with upper tract damage from high pressure in the bladder in utero. And these boys, posterior urethral valve is the name of the group, but there are all sorts of definitions of these membranes. They do very poorly after puberty, and a lot of them do go on to have significant renal problems. But they are asymptomatic, so they're a very difficult group to keep adhered to treatment and to surveillance because they feel fine and they're adolescents. So here we are, we've just got one of these urodynamic traces showing you that the bladder is building up some pressure, but despite this high pressure, the detrusor isn't able to push the urine out at the rate that you would expect. So there's something going on to stop that. Is it at the bladder neck? Is it in the urethra? This test just doesn't tell us where it is. Now we have a thing called bladder neck dysfunction. Remember I showed you in the anatomy picture where at the entrance to the urethra, the area we call the bladder neck, the fibers from the bladder come down and just go in to that area of the bladder neck, so that if the detrusor muscle contracts, something happens at the bladder neck. That means that the bladder neck, when the detrusor contracts, the bladder neck will open. It's different to the internal sphincter and to the external sphincter. And we know in adult men there's often a dysfunction at the bladder neck, which is often the reason why they have hesitancy in their population that can't start their urine. Now there's a group in America that have identified this in some children. 95% of the children who they've identified this in, they tell you they have hesitancy. They say, I'm at the toilet, I want to go and I can't. Now, most of our kids won't tell us that when we ask them. Most of them won't tell you that. So this is a symptom or perhaps a disorder that we might see in less than 10% of our kids who would have wetting problems, and you won't see it if they don't have hesitancy. So that helps a little bit. And the way we measure it is that there's a lag time in when the pressure drops here and when the voiding starts. And the critical lag time here is said to be about 4 seconds. Now we did a big analysis of our adolescent data in children who were wet but didn't have didn't tell us about that symptom of hesitancy. We were blinded to that. And this lag time was normal in the sense that there was a lag time in lots and lots of children, but it was only in the ones that told you they had hesitancy that it's a clinical issue. Now there are some disorders of the stream that you can make yourself. You know that boys are very good at peeing high and peeing low and peeing close and peeing far and missing the toilet altogether. You can stop and start your flow of urine at will. You can do all sorts of clever things. You can be taught by a mother who thinks that the sound of urine is terrible. You can be taught to make silent urine. You can do all sorts of things. So there are some conscious flow rate disturbances that you can do. One of the things you need to be aware of if you have a Uroflow machine is that when you ask the child to pass the urine on a Uroflow machine, if they have a strong stream, they'll alter it so that it doesn't go out of the machine and onto the floor. So it's a confounder to what you might find. In boys, you know, they can start their flow of urine. They're a bit busy. They can press the urethra with their hand, and they can stop the flow of urine and off they've gone, but this will set up some local irritation in that part of the urethra. Not a good idea. And we're going to talk about voiding dysfunction later, but it's nice to show you. Here we've got an unstable detrusor contraction, nothing happening in the pelvic, in the abdomen, so we know it's really coming from the bladder. And then here we've got an interrupted flow of urine. Something's happening so that the urine isn't either being pushed out continuously or something is stopping it here. And this is probably an obstruction, which we'll talk about later in rehab. And this is part of the unconscious interruption of flow of urine. And it may well be the toileting posture, it may well be the learning from the early days, some discoordination of the smooth muscle and the voluntary muscle. It may well be that there's very high pressures being generated inside the bladder, so you use the pelvic floor and the voluntary structures to create a brake on that, to inhibit the pressure as something to protect the upper tracts. It may well be that there's some other neuropathic reason